Here you can see it goes by itself, or I'm not doing anything. This is the case presentation. A 71-year-old man with a rather normal BMI, no relevant medical history, just tonsillectomy, no allergies, really standard patient. And this is his urologic history. He had LUTs in therapy already with the most selective alpha blocker we have, silodazine. You can see 15 score of IPSS, a quality of life of 4. And he had a modest leak of urine, reducing his quality of life. No previous urinary retention, no previous biopsies. The PSA was normal. The digital rectal examination showed a very large prostate, not suspect for PCA. The uroflowmetry was pathological, and the transrectal examination demonstrated a very large prostate, 220 cc with an adenoma of 130 cc and a post-void residual of 80 cc. We performed the MRI just to be sure, because he was rather young and it was negative for target areas. The MRI is a very good anatomic study for the shape, size, and the relationship with the neighboring organs and structures. So it's very good before an enucleation of a large prostate. And he also performed urodynamic pressure flow study because of the urgency and the urinary leak he had pre-operatively. And the trusor hyperactivity was demonstrated secondary to obstruction. So this is the TFL we have been using, the Quanta fiber dust laser system. I have to say that we use a lot of kind of lasers, Holmium and TFL, and among the TFL, not only the Quanta, but of course also the Storz, Coloplast, EMS, Olympus, any kind of laser, because you know we have a lot of courses and a lot of collaborations with all the companies, and the settings are always the same in any case. For the enucleation, 1 joule of energy and 30 hertz of frequency, short pulse length because of the low peak power of the TFL. And for the coagulation, we use 1 joule per 20 hertz with the medium, depending on the guide user interface, medium or long pulse length. The fiber is the 550 micron fiber. And we can go to the next one, thank you. And you can see here the enucleation set. We use, of course, the source image S1 camera, the telescope with a 12 degrees optic lens, although we tried also the 30 degrees and it's also well working. For the morcellation, we use the Storz nephroscope, and the continuous flow is a sheet of 26 Charvier, and then the Kunz laser working element, which has a tapered channel for the fiber, avoiding it to move during the enucleation and do very precise incisions and enucleation of the adenoma. For the morcellation, we used in this case, as often we do, the drill cut X system by Storz. Go to the next one, thank you. I just wanted to show you quickly the OR setup, which is very important, and I confirmed this after going a bit visiting some centers and performing endoscopic enucleations, because you have to be sure to have everything to do a good endoscopic enucleation, otherwise you might have problems. And of course, the possibility also to elevate the bags very high during morcellation to fill the bladder, and a good video system, of course, and all your sets. We also always have the resectoscope, the bipolar one, on our scrub nurse tables, all the pedals of the bipolar, of the laser, and of the morcellators, a good aspiration during the morcellation, because you see here the pump, but it also a good aspiration of the pieces to be retrieved for histology. So everything must be ready. The next one, please. You see here, operation time. In this case, it was a big prostate. It was 84 minutes. The enucleation time was very quick because there was a very big protrusion into the bladder lumen, and the lasing time was 37 minutes, almost 38 over 48. So a good ratio, demonstrating that we didn't lose much time looking around, but worked very smoothly and continuously. Energy used was rather low, 66 kilojoules. Morcellation time correlates more with the effective weight of the adenoma, was 14 minutes. Tissue weight was 130 with a very high enucleation efficiency, 2.7 grams per minute, and a very high morcellation efficiency, 9.3 grams per minute. We had no intraoperative complications, and afterwards I'll show you also the post-operative course, which was uneventful. So here we can see the video of the surgery, if we can have it starting. We always start during endoscopy, of course, to assess shape and size of the gland. It had a very good protrusion into the bladder lumen, which was helpful, of course. We didn't insist to see the orifices because we don't want to have bleeding before starting the enucleation. And here we start, you can see from the drawings, at the apex of the left lobe during the reverse mucosal incision around the verumontanum, which is the usual technique we adopt, to go and look for the enucleation plane. This is TFL. You see the settings allow to avoid the brownish aspect of the tissue. It looks more or less like holmium, and the incision and all the work is useful if it's always somehow symmetrical. And here you can see we go all around the verumontanum. This is a non-ejaculation sparing surgery, so we are just nearby the veru and not 1 centimeter above it. And I think you can appreciate that coagulation is also very good during the incision. Usually the mucosa bleeds a lot. And here at the apex of the left lobe, we look with this incision for the right enucleation plane. And this is the only moment when we push a bit, we do a bit of blunt enucleation of the apex because we want to put in tension the connective fibers between capsular plane and adenoma. Once we have seen it, as you can appreciate, we go on the other side and we do the same on the other side, connecting the two incisions. And we go from, let's say, 5 o'clock up towards 3 o'clock on the left side. But here we go on the right side and we also prepare the apex on the other side, incising the mucosa. The mucosa is often rather thick, so the incision has to be deep enough to evidentiate the plane. And here you see the plane when it's nice like this. You can see it because it's very shiny and smooth. And this patient had no biopsies, no prostatitis, so probably the expectation of the surgeon is that the plane is mature and develops rather easily, just elevating the adenoma with the beak of the endoscope. So we are preparing the first reverse U incision around the apex on the right and on the left side and around the verumontanum before going and prepare the early release of the sphincteric mucosa. Here you see just pushing a bit and evidentiating symmetrically the plane. Now here you see we start with the second mucosal incision. It's again a reverse U incision. It has to be again deep enough to reveal the adenoma underneath. And this incision is very important because performing it now, you avoid to do a traction during the whole enucleation of the sphincteric mucosa while reaching the bladder neck. So the adenoma is freed from this mucosa. You avoid a risk of sphincteric destruction and of transient post-operative urinary incontinence. Of course, the incision has to be deep enough and on both sides. The other important thing is that you see, we are not incising at the periphery of what you see, but a bit towards the bladder, the urethral lumen, and then a bit inclined towards the bladder neck, because we have to remember the anatomy of the sphincter. And as in QRP, when we go at 12 o'clock, we don't cut exactly at 12 o'clock at the same level of the verumontanum, but we go a bit more inside to avoid post-operative incontinence. The same we do with this incision. We free the mucosa, we stay inside, not on the white line, which is the sphincter. So we avoid to cut the sphincter, and we go a bit towards the bladder neck in order to free this mucosa from the very beginning. And at 12 o'clock, this is important as well. The other important thing while you are working to avoid to put in traction the sphincteric mucosa is always to work with your scope pushing centripetally and not pushing towards the bladder neck too much. Always pushing centripetally towards the bladder, the urethral lumen. Here you can see we are completing the 12 o'clock incision. The mucosa might bleed a bit, it might happen. And when we finish, we go under, this is the left lobe, and symmetrically we free from 5 to 3 o'clock and from 7 to 9 o'clock under the two lateral lobes. If we encounter peripheral adenomas, we include them in the enucleation, and we always try to have a bit of perspective, not to stay too near to the plane we are developing, but to have a bit of distance to always check where we are going. Here you see we are at 2, going 1 and towards 1 o'clock. Always elevating and putting in tension the connecting fibers between adenoma and the capsular plane. And in the meantime, you can see also the fact that this laser is also coagulating very well. Here we are at 12 o'clock. So while we enucleate, we also coagulate, and it's very rare for us to switch to the second pedal, the coagulation one. We only use it for very big bleeding blood vessels. And you also know that we don't have to hit perpendicularly the bleeding vessel, but we have to go around because we have to try and arrive on the bleeding vessel very delicately. Can you start the video again? Yeah, thank you. Because you want to avoid to make a hole and push the bleeding vessel inside. You want to seal it and to close it without having bleeding, because the primary chromophore of TFL is, of course, water, saline. So we have to have a clear view and trying to seal the bleeding vessel laterally or going all around the bleeding vessel. You also see that we usually use the so-called no-touch technique. This was very evident when using holmium-YAG, which has a high peak power and bigger vapor bubbles. For TFL, we also use a no-touch technique, but because of the lower peak power, we have smaller bubbles. It's not a single bubble, a double bubble, or a modulated bubble. It's a stream of small bubbles which require to stay nearer to the tissue we are treating. And you see, almost in touch, but not really in clear contact. And in this way, we can also use the small bubbles developed by TFL as we do with holmium. Of course, the features are different. And the other important thing to remember for TFL is that you stay too far. It's it's 2 point something times more absorbed by water, not 4 times, because someone calculated on a linear scale and some others on an algorithmic scale, but in any case, it's almost twice as holmium. If you stay too far, all the laser energy goes into the irrigation. If you stay in touch, of course, you in size, but if you stay near about 1 millimeter, you can use the no-touch way also with TFL, as you can see in this case. And we have a stream of bubbles, which are much smaller because of the question of the peak power we were saying. And the other important thing I want to underline with TFL, differently than with holmium, is that you don't have to stay always in the same place, because TFL has more potential for photothermal damage if you stay always in the same place. And this is the reason why the technique of enucleation helps you somehow. And in this way, you avoid to have irritation also of the nerves into the capsular plane. In the meanwhile, you see, we have done the whole way around the adenoma, and we are reaching the bladder neck, also coagulating. When you start seeing bleeding in your plane, it's because you are going into the thickness of the bladder wall, which is thickened and hypertrophic. And at 12 o'clock, you join the incisions. Until now, the bladder lumen was not in communication with your plane of work, but now you have the irrigation not only in between adenoma and capsular plane, but also in the bladder lumen. So you have less occasion for resorption, even though it's a line. And now here, from 12 o'clock, you go down on both sides and you do bladder neck sparing enucleation of the adenoma, going down and trying to join the already enucleated inferior part. This is on the left side, of course, and you can follow it very well, always checking where you are going until the angle under the left lobe, and you arrive until the bladder neck on the left side, joining all the reference points. And to have reference points is always very, very important. And then when you join, you can also work laterally, going under the median lobe, remembering that it's for free. So here you see it's completed on the left side. We go on the right side, going down along the bladder neck. We call it bladder neck sparing surgery. You see here the coagulation, which is very efficient. And you go all around trying to seal the blood vessel, because if you stay only on the blood vessel, you push it inside. And this is not important for the adenoma, which will be removed, of course, but it's very important for the capsular plane. And you see the laser is always firing somewhere else, somehow upwards and not downwards towards the orifices, which we have not seen because we didn't want to have a bleeding adenoma from the very beginning. And here you see we are always a bit separating the two structures we are enucleating and trying again to reach also on the right side the already enucleated inferior part. Then when this work is done and you are on the bladder neck in the inferior part and you have your adenoma already enucleated from below, you have to work under the bladder neck, remembering that if upwards at 12 o'clock you were following the shape of the adenoma going downwards, here under the median lobe you have to go upwards, and this is very important. And all these movements seen from outside, from external, are very important because you have to be very delicate, remembering that you have a straight, rigid endoscope inside a urethra. If you move too violently, you're going to use a lever which has the fulcrum on the sphincter. And so you might have trouble if you move too violently and angle too much and so on. So always very delicate. And another option, of course, is to use also miniaturized accesses when you have very small and not compliant urethras. You know, we have the 22 and also the 18.5 French mini resectoscope for enucleation and morcellation. But here the urethra was fine, so no problem at all. But this is very important also to have a good lubrification of the external meatus and of the whole instrument endoscope you are using. You see here we are always very symmetrical. We always work on both sides, left and right, because we don't work only on the right or only on the left. We try to be very symmetrical. And here we are joining under the median lobe, laterally, and preparing the angle to go upwards under the median lobe. And so we can go all around the adenoma, elevating it and avoiding to undermine the bladder neck. And we are almost done with the enucleation. And in the end, you have to do it always checking, of course, what you're doing. In this case, it's nice to avoid to have the adenoma falling into the bladder lumen, because otherwise it pulls the mucosa and it's more difficult to detach it from this last part at 6 o'clock of the bladder neck. So we do it very progressively, always checking. And for this very last part, we are almost done. And then we push it into the bladder and do our hemostatic revision, which sometimes is very short, because you have seen that hemostasis has been done step by step during the enucleation. But for a good morcellation, you have to have a perfect hemostasis, because the quality of vision during morcellation is essential. And for this reason, it's very important to not to have bleeding, bleeders anywhere, and so to check everything. And of course, after morcellation, we will do the final hemostasis before putting the catheter. This is the very last part. Usually the bladder neck is large enough to allow to push the adenoma inside the bladder lumen. And you see, always firing not downwards where the orifices are supposed to be. I know I have only 2 minutes left, and but I think it's almost done, because I've used some of my time to show you the previous slides. And I think we can just have a look at the beginning of the morcellation, which is, as you have seen, was very efficient. We are just pushing here. Sometimes there is a bit of connecting fibers to check and to cut again. But here you see it's in the bladder lumen, and after hemostasis you go for morcellation. The movement of the blades is laterally. The efficiency is very high, blades last up to 100 minutes of life, and until then they work very well. The aspiration has to be very good. The bladder filled, completely filled with no outflow, only irrigation inflow, 2 elevated bags, not too much inside with the morcellator, in the middle of the bladder lumen, not moving and not chasing pieces everywhere. The post-operative course was uneventful. It's easier to remove the catheter after large prostate enucleations. And so in this case, the removal of the catheter was very efficient. And before putting the catheter, of course, we always put a silicone 20 French catheter with a balloon on the bladder neck. We always check everything, orifices and sphincter with the bipolar before finishing. And usually we leave the irrigation until the morning afterwards, and then we can remove the catheter the first post-operative day or the second post-operative day. We are looking for the orifices, checking them in the end. First one, you see it's rather very much on the border, as it happens in very large prostates, but it's intact, and the other one is on the other side. So I think we can finish it here. Maybe there is also still the sphincter to be seen. We usually empty the bladder. There is the second orifice. You empty the bladder, you go inside the urethra, and without irrigation, you check whether the sphincter closes or not. This is what we do usually. We go inside, we check. If it closes, you're happy. You don't have to see the lumen of the bladder from there. And this is all. Thank you very much. You see here the BPH and chronic prostatitis histology, patient dry, and good post-operative course.
Thank you, Cecilia. This was a very nice demonstration of the enucleation using the TFL. Can you tell us about the properties of TFL compared to the conventional thulium?
Yes. Let's say conventional thulium, you mean continuous wave thulium?
Both.
Yes, of course.
Yeah, because now we also have the hybrid one with the pulsed version, let's say. So TFL is very similar as wavelength to holmium YAG. It's completely different laser because it doesn't have a crystal with the ions inside. It has a very long fiber inside the device, which is smaller, air-cooled. It does not require dedicated plugs, electrical plugs and so on. Is a bit lighter and a bit less noisy, and it doesn't heat so much as the holmium, and probably I'm not very expert in thulium YAG. And it has a shallower penetration depth, and it's more absorbed in water, as we were saying. The difference is that it's a pulsed laser, if we want to compare it with thulium laser, thulium YAG laser, of course. So it's thulium, but the thulium ions are inside the silica fiber, inside the device. While for thulium YAG, you have the crystal doped with thulium ions with the flash lamp exciting them. While for TFL, we have diodes, which are in couples. And I was trying to understand, for instance, why, because we were said, oh, so if the machine is not so complicated as holmium or thulium YAG, why is it so expensive? Because thulium diodes, laser diodes are very expensive parts of the laser. It's not the architecture of the device, but the diodes that are pumping the thulium ions. So the output is more efficient because you don't have the alignment, you don't have the mirrors, the partially reflecting or the totally reflecting one. You have only a small mirror, and the connection with the fiber is almost direct. So most of the energy goes into the fiber, the working fiber that you have.
Basically, Cecilia, this is a thulium laser that works like a holmium laser because the effect on the tissue is completely different from what you are accustomed to see with a standard thulium laser working. It's the charring, so on. It's effective as well. But particularly impressive in this demonstration, and I remember that one year ago I came to Torino to see you working on with this tool, is that the action is so similar to holmium that it resembles holmium much more than thulium. Anyway, I think that we all agree that the technical principle that you explained are exactly the same for any power source you got in your hands. And first of all, you got to put in safety the sphincter, and to isolate the sphincter from any traction. And thereafter, when you follow the correct plane between the peripheral transitional zone, you should follow it without losing it, because this is much easier with this device because the tissue is white, and the correct plane is whitish, and so it's much easier to follow it. A very important concept that you explained is that your enucleation from 6 o'clock to 3 and 9 is centripetal, and from 9 and 3 to 12 o'clock is centrifugal, and from 9/3 to 12 is centripetal. That means that you avoid going into the peripheral zone and to cross the heavy bleeders of the prostate that can be quite difficult to seal if you're not an expert laser surgeon. But using this approach, this technical approach, that's a common experience. Enucleation is a safe procedure that can be performed in complete safety for you and for the patient, with the excellent functional and anatomical results, as we have seen at the end of the procedure. That even the hemostasis was absolutely excellent, because you saw that with the bipolar you didn't perform anything basically, and this is related to the effect of the laser and because you follow the correct plane. You follow the correct plane, you do not have any huge bleeder on your road, and so you're not compelled to lose time and to have blood that is stained your operating field. That can be a little bit confounding if you're not so expert. So it's very, very nice, right?
Thank you.
Cecilia, do you apply any measures to reduce thermal injury?
Yes, I tried to say something during the procedure. The best thing to avoid thermal injury, the first thing is to have a good irrigation inflow and a good irrigation outflow, of course. This is the first thing. The second thing is not to use the warmed irrigation bags. Use it room temperatures, not cold, of course, but room temperatures, because sometimes we also have warmers. And the other thing is to move continuously. This is the totally unblocked enucleation with the early release of the sphincteric mucosa. And the most important thing, even more important for TFL than for holmium, is not to stay always in the same place with the fiber. You have to do your enucleation digging the plane between adenoma and capsular plane towards the bladder neck, following the shape of the adenoma, but not staying always in the same place. If you decide to stay between 5 and 3 o'clock, always working there, you will create a lot of thermal damage there, of course. So if you always rotate all around remembering where you are and always having a good orientation, the movement and also, of course, also the expertise you have will avoid thermal damage and related post-operative problems, of course.
We have a question. Oh, please, Ago.
No, sorry, Stavros.
We have a question from audience that goes to you, Cecilia, but also I would like to invite Thomas and Jean-Baptiste to ask to the question, because it is the same question also for all the enucleation techniques. How can we prevent any problems with ejaculation? How can we preserve ejaculation?
I can answer for this patient, and in this case, we always discuss this problem with the patient. There are patients that don't really care, as this one. So I said from the beginning that the first incision around the verumontanum was not ejaculation sparing. If we have young patients willing to preserve ejaculation, it's very important to define the strategy. If they're very young, maybe you will not go immediately for endoscopic enucleation, but maybe you will try alternative measures, bladder neck incision, middle lobe enucleation, urolift, or what else of minimally invasive surgery. But if the prostate is like this one, is an obstructing one, and the patient wants to try and preserve enucleation, you can say, I can try and spare at least 1 centimeter all around the verumontanum at 6 o'clock, of course, and going down, because you have seen the exit of the ejaculatory ducts around the verumontanum, and so you have to spare them and stay above. But remember that maybe if you do that, you have to evaluate the shape of the adenoma, because if you have an adenoma with the apexes going very much below the verumontanum, this might become a problem, because you want to free them from the mucosa, then you have to elevate them and hope to spare enough tissue around the verumontanum to do an ejaculation sparing surgery. But with a real enucleation, it's not always successful, I can tell you that.
Jean-Baptiste?
Yes, to spare ejaculation, you have two things to respect. You have to respect ejaculatory hood. So what is ejaculatory hood? It's the verumontanum, the posterior urethra above the verumontanum, 1 centimeter or 1.5 centimeter above it. The lateral structures of the verumontanum, you have to spare this to spare the ejaculatory ducts and the ejaculatory meatus, and you have to spare also the lowest posterior inferior part of the apex. So you have to keep some tissue to have a watertight ejaculation, what I call a watertight, because you have the ejaculatorius muscle, which is behind the verumontanum, will push directly the verumontanum during ejaculation inside the anterior urethra to have ejaculation. And then at this moment, to be watertight, you have to spare the posterior inferior part of the apex. So it has been very well demonstrated by aquablation, because when you have aquablation, you have the first step of the aquablation is going to be like this. So you're going to have the water is going to do a channel inside the prostate, but at the apex, and you can manage it on the preliminary treatment and the planning of the aquablation, you have what they call the butterfly water jet, which is like this at the apex. And with this, you spare the inferior part of the apex, and with that, you can in the literature, it's more or less 75% in laser surgery to where you can prevent ejaculation. But you have to keep these two things. And what is difficult, especially with the holmium, is to cut inside the prostate adenoma to keep this part of the apex. And it's quite difficult to do with the holmium. It's better with the fiber thulium laser because you cut very well inside the prostatic tissue.
Thomas, and does this compromise the functional outcome?
We don't have long-term data of that. We just have long-term data of Shanas Alusni. He published this in Journal of Endourology with a modified TURP, so ITER, and he had 12.5% 5 years treatment rate with TFL. And what Jean-Baptiste just said is exactly would result probably in the same thing. So we will have a compromise of probably durability. If we have a large prostate, we have a high dynamic of regrowth. If we have a small prostate, maybe not. But if we have a 150-gram gland and do something like this, we will have a high regrowth rate as well, because that will be the same tissue that will regrow. But I would agree with Jean-Baptiste. We need to have energy sources where we can cut extra anatomically, and this must be a better vaporizing laser than Holmium laser. If you use TFL, I would use Thulium continuous wave or something like that, because there you can really cut through, or you simply take Bipolar. But in principle, butterfly aquablation, I don't like to bring aquablation with regard to ejaculation sparing, because it's simply anatomy. Because we know from Meneghini prostatectomy, if you keep the whole prostatic urethra intact, you will end up with 100% integrate ejaculation, which not always happens with open prostatectomy or robotic or laparoscopic prostatectomy to keep this intact. But that is the maximum. So I always say, if we don't want to change your ejaculation, we simply have to do nothing, because then the ejaculation will be as such as it is. So if you consider any treatment, and even UroLift, that is I always call one where you have already not only ejaculation suffering, but also erectile dysfunction could also happen if you use this not only in the studies that led to the entrance of UroLift. So there is a small percentage. So if the patient really wants to be safe with regard to his ejaculation, he has to understand that the only chance to not change the ejaculation is to do nothing.
Nothing.
And this is what I let the patient write down. If I don't want to change my ejaculation, I have to do nothing, because that is what the patient has to understand. And understanding this, everything comes after that. And I think enucleation and ejaculation full template does not work. We know that 40, 50, maybe 70%. With 70%, you already do some compromise with regard to radicality. So I think you really need to choose something else to spare ejaculation. And it's already a concept from 1994. Look at the old Dorschner and Stolzenberg papers. Everything is described very nicely, what to prevent: musculus dilatator urethrae ventrally, musculus ejaculatorius dorsally, and maybe a lot of apical mucosa sparing around that you stand a chance to keep it.